So I will just say welcome to our first health equity webinar. This is part of our one of our activities, and we have a new funding agreement from CDC that focus on health equity, diabetes, pre-diabetes, and community health workers as well, building the workforce. So again, welcome. Good afternoon. Today we will explore strategies and initiatives aimed at advancing health equity in our communities. We all know health equity is essential for ensuring that everyone has the opportunity to attain a highest level of health. This seminar will provide valuable insights and particular approaches to addressing health disparities and promote health equity in health outcomes. Again, thank you for joining, and let's get started. So let me just see. Okay. So we will start off first just discussing the difference between health equity and health disparity. Sometimes it can be confusing or people might get it confused. So I just want to at least start off by making sure we clear and understand the difference. And so health equity refers to the principle that everyone should have a fair opportunity to attain the highest level of health, regardless of the factors, if it's gender, socioeconomic status, race, ethnicity. It emphasized on the absence of avoidable, unfair, or unredeemable differences in health outcomes. And in Maryland, like many other states, not just Maryland, disparities exist in health outcomes or access to healthcare based on factors, not just on race, but income, education as well. Health disparities are a result of a broader social inequities, and can manifest in various ways, such as higher rates of chronic disease. And in Prince George's County and Maryland, we have a high rate of diabetes and prediabetes, as well as hypertension and cardiovascular disease. And on a few charts throughout our presentation, you'll see some statistics for the state of Maryland, as well as Prince George's County. And so achieving health equity requires not only addressing the health disparities, but also the outcomes and also tackling the root causes of these disparities, such as poverty, discrimination, and lack of education. Next slide. And so here, this chart shows some health indicators, and we can receive this information from the PG Health Zone. So we have a link in one of the last slides that you have a reference. I think it's actually a good resource for everyone to actually review and see the impact of chronic disease within the county, Prince George's County, and how it compares to the state of Maryland and also the rest of the U.S. So here, the first part is broken up by state and the county. As you can see, in the state of Maryland, 9.8% the population has diabetes, while Prince George's County rate is 11.1, which is higher. You'll see that across the board. You see the same for prediabetes in Prince George's County is 16.6% compared to the state of Maryland, which is 13.5. And we all know that Prince George's County, they have a high population of African Americans as well. And also our Hispanic rates population has been growing over the last couple of years. So also you can see the hospitalization rate due to type 2 diabetes is also higher in Prince George's County compared to the state of Maryland, 15.2 versus 13.9. And then when we drill down by race, you can also see the difference as well. And as you make note, the prevalence of diabetes in Hispanics are higher, is 11.7%. And in African Americans, 10.9, and then white, 7.1. We didn't have the actual numbers for that prediabetes for Hispanics, but I know our Office of Assessment is working on that data. So it might be updated in our community needs assessment. And we also have a link to that as well. So you can review this information. And so, just back once. Okay, yes. And so you can see that prevalence of prediabetes in Black Africans Americans is 19.5 compared to 13.2 to white counterparts. And then for the hospitalization rates, you can see it's also higher in African Americans as well. Next slide. And so also some of the socioeconomic factors includes children. This is data from 2019 that's also on the Healthy Zone website. 14.5 of the county children are facing food insecurities, excuse me. And also 12.6 of children are estimated to live in poverty in Prince George's County. 1/3 of the Hispanic female population heads the household family, which they also live in poverty. An estimated of 9.2 of the county households do not have a vehicle. So we have CHWs that help a lot with the social determinants of barriers, and this is one of the main resources we see based on our project within Prevention Link, and we have some CHWs speaking this afternoon as well to share more of their stories. Also, the unemployment rate declined in the county, which is a good thing. But on the other hand, you can see that it still remains higher for Black residents at a rate of 6.5%. And for residents with a disability, the unemployment rate is actually higher, 12%. Next slide. And so some of the initiatives that we're doing in Prince George's County within the health department, I would like to share some of the initiatives that we currently have going now. Since we have developed a community workforce within the county, we receive funding for CDC, which is known as our CHIS grant. During that grant, they has trained over 90 CHWs in the state. They received their certification. Also, they currently funds 30 CHWs internally and through 3 other county-based organizations, which includes CASA, HCDI, and Total Lincoln Care of Maryland. Also, the Prince George's County, they team with the Healthcare Action Coalition, which started the care coordination meetings. Those are monthly. Monthly. They have work groups as well. And part of the coalition, they have memberships that include hospital systems, government organizations, community-based organizations, payers, and ambulatory providers as well. Also, the Community Care Coordination Team and Prince George's County Health Department are working to identify and launch a community resource inventory, which will help care coordinators identify and refer to high quality resources for social determinants of health barriers. So we've been looking at 211 and also Aunt Bertha. So that's in the works as well. Also, we have the PGC, the Health Department's Health Assurance Program, which reimburse federal qualified health centers for uninsured patient visits through helping to offset the cost of uncompensated care for the federally qualified health centers, regardless of the race. Also, we receive federal funding from CDC, which is our 2320 funds, which is sponsoring this health webinar, which allow us to assist and collaborate with community-based organizations and small community pharmacists to help target populations to prevent chronic disease, such as diabetes. Okay. So those are some of the things that we're moving forward and working on in Prince George's County, and there's more to come. So we're glad you can partner with us, and we're looking forward to continuing this partnership. And I'll let Tanya take over.
Good evening, everyone. My name is Dr. Tanya Henderson, and I'm the program coordinator for Prevention Link. And I'm going to be the moderator for the balance of the webinar. Delegate Ashanti Martinez is not here yet, so we're going to go on with the program. And whenever he joins, I'm going to bring him on. So next, we're going to hear from Judy Lichty Hess, and she's going to talk about the Americans with Disabilities Act, Bill of Rights. Judy?
Thank you, Ms. Tanya. So Here we go. The first slide. So, the COVID pandemic shined a light on the disproportionate toll on minorities, low income, and historically underserved Americans. The National Institute of Minority Health and Health Disparities found that the racial and ethnic disparities cost the U.S. economy $451 billion in 2018. This is a 41% increase since 2014. Deloitte found that these inequities in the U.S. health system cost $320 billion, and it is thought this figure could grow to $1 trillion by 2040 if nothing is done to address the problem. With that in mind, the American Diabetes Association developed a Health Equity Bill of Rights that envisions the future without health disparities, encouraging patients to make their voices heard. So, here's the call to action to healthcare leaders and policymakers. The first of the 10 is around patients being able to have access to appropriate medications. Growing numbers of patients cannot afford the medications they need to survive. An example, 1 in 4 insulin-dependent people with diabetes say they have to ration their insulin. The second is the right to have healthy food. The poorer you are in America, the less likely you are to have a grocery store within walking distance of your home. Truly, every American with diabetes and prediabetes must have access to affordable, culturally relevant food and the information they require to eat healthy. Do you know if their patients with prediabetes and diabetes have the foods that they should eat or not eat? The third right is to have insurance that covers diabetes management and future cures. Sad to say, diabetes is the most expensive chronic condition in the US, and people with diabetes incur medical costs nearly 2.5 times higher than others. The ADA is recommending that all people with or at risk for diabetes be covered by a robust health insurance. The fourth Bill of Rights is not to face stigma or discrimination. Patients with diabetes are protected against discrimination at work and school, but sad to say, the diabetes community still faces many barriers to equal treatment. There is diabetes stigma that includes negative attitudes, judgment, and even prejudice. This can be internal and external. So internally, this can be a self-blame, shame, and even guilt. And the external stigma include things like mean looks, rejection, and exclusions. Avoiding preventable amputations is the fifth Bill of Rights. Do you know that every 4 minutes a limb is amputated due to diabetes in America, and that most of them are avoidable? In fact, the risk of amputation rises among communities of color. African Americans have twice the amputations than whites. This is where it is important to help your patients manage their blood sugar. Proper foot care is essential. Like blood pressure, when you're getting it checked every day, patients need to be checking their feet every day for sores and other things. Next slide, please. There is an inadequate diversity in clinical trials to test drugs with people with diabetes. The sixth right is to participate in clinical trials without fear. As you know, there have been troubling history and mistreatment of minorities in medical research. It has been recommended that every effort must be made to invite a diverse range of participants in drug trials, but ensure everyone is protected by the process. The seventh Bill of Rights is something that you may know who work with me with Prevention Link is focusing on, and this is the right to stop prediabetes from becoming diabetes. As some of the practices know, I have helped them identify patients with the appropriate patients with diabetes or diabetes prevention to make sure that they're identifying those patients, and then also even patients that may not even had an A1C test that is done. Prediabetes and diabetes are often preventable, but low-income, minority, and historically underserved communities see the highest incidence. The right to build an environment that does not raise the risk of getting diabetes is the 8th Health Equity Bill of Rights. When you are talking with your patients about exercise, do you ever mention that they do not, or do they ever mention that they do not have a safe place to exercise? Historically, underserved communities not only see the highest diabetes rates, but also face the greatest barriers to safe places to live and exercise, to have clean air and clean water. The things that mitigate diabetes onset and related to other risk factors. All Americans are entitled to access to an environment that allows for a healthy lifestyle. The 9th right is the right to the latest medical advances. We have been hearing more and more about technology like the continuous glucose pumps, insulin pumps, artificial pancreases, and new medications that can be instrumental in treating and managing diabetes. What we are seeing is many people with diabetes in the lowest income brackets do not have the same access to these safe, life-saving technologies as do their higher income peers. Basically, insurance does not support these technologies. If everyone had the access to these technologies, could you imagine the positive impact that it would have on diabetes? Lastly, the right to have your voice heard. Every community should have a say in how their needs can be addressed everywhere from the doctor's office to the ballot box. There is, at the end of the presentation, there are some resources that you can take a look at that actually show you the Bill of Rights. Thank you.
Thank you very much, Judy. Our next speaker is Delegate Ashanti Martinez, and he's going to speak about the impact of health equity. Delegate Martinez?
Hello, can you guys hear me, see me, any of those things?
Yes, we can hear you. We could see you, but now you're not in the camera anymore.
How
There
about
you
now?
go.
Okay,
Yeah.
perfect. Well, thank you guys so very much for the invitation to join you this afternoon. It is always a pleasure to be with other Prince Georgians, particularly talking about something so heavily important, which is health equity and healthcare. I'm Delegate Ashanti Martinez. I have the honor and privilege of representing Maryland's 22nd Legislative District in the House of Delegates, and I serve on the Health and Government Operations Committee. I serve on 2 subcommittees. The first subcommittee is Public Health and Minority Health Disparities, and the second subcommittee is Health Occupations and Long-Term Care. And so with each of these subcommittees, I have a front row seat at what the state is doing to tackle a lot of the issues that were just addressed regarding health equity and health disparities. You know, one of the things that makes Maryland unique is that we actually have a commission on health equity that was established in 2021 to look at all the issues that you brought forward and figure out how best as a state can we utilize our resources to impact the communities that are not receiving the care necessary to be as healthy as possible. You know, we want to make sure that we're using every single state dollar appropriately as possible to advance the care for all of our communities. And so whether that's building new facilities in one part of the state or encouraging, you know, higher pay for doctors in another, we want to make sure that we have a blueprint for how best to tackle these issues. And that commission is doing that work day in and day out. Something else that I wanted to talk about too was the work that we've done this legislative session. You know, I'm really proud to be on the Health and Government Operations Committee. It's one of the hardest working committees in Annapolis, not just because of the work product we do, being that we're the only committee to see every single bill that was assigned to us and have a hearing for every single one of those bills, but we also are really deliberative in the work product that we produce and the care that we try to make sure all of our bills have, because we understand that healthcare doesn't care if you're a Democrat or Republican. We want to make sure that we're providing the necessary care possible to all Maryland residents. A bill that I wanted to, there's 2 bills actually that I want to highlight for you guys that kind of tackle the health equity space. Unfortunately, I didn't have anything to bring up about diabetes in particular, but one of the bills I wanted to address was House Bill 1293. It's the Maryland Department of Health Public Education Campaign for Prostate, Lung, and Breast Cancer Prevention. And I bring this up because education, and I think many of you know this, is such a pivotal role in the determinants of how people manage their lives, manage their care. and making sure that we are as proactive as possible and not simply reactive when it comes to healthcare and health disparities is really key. And bills like this ensure that the health department is using state resources to do just that. Another bill that I'm actually really proud of, because it was a bill that I championed as the lead sponsor, is House Bill 865. It's the So Everybody Can Move Act. And so we just talked about folks that have diabetes being, impacted by limb loss and limb difference. Well, this bill would allow for insurance coverage, whether through Medicaid or private providers, of an activity-specific prosthesis. Right now in Maryland and many other states, if you want an activity-specific prosthesis, it's usually not deemed medically necessary because you already get a daily prosthesis provided through insurance. So the So Everybody Can Move Act, which will be signed into law next month, is going to change that. It's going to make sure that we have a more equitable approach to folks that are suffering from or living with, more so, limb difference and limb loss, to allow them to get a prosthesis to swim, to lift weights, to run, to be able to go to the beach, just have a holistic life, because we know life doesn't end once you lose a limb, and you shouldn't be prevented from being able to move and be active, because a sedentary life, we know, also has health impacts to you as well. Something too that I think for those on this call that are interested in research, that are interested in how best we can move our county forward, I would offer the RAND report. It is the Assessing Health and Human Services Needs to Support an Integrated Health and All Policies Plan for Prince George's County. That report was released in August 2021 and has a lot of great recommendations for Prince George's County on how we can move forward in a way that we're looking at equitably our policies in relation to what we do with the state, how we're doing getting federal dollars, but ultimately how are we spending our resources here in the county to make sure that the health outcomes for our folks are better. And last thing, I want to bring up is the budget. Our budget is a reflection of our values, and I firmly, truly believe that. And something that was mentioned on a previous slide was the Health Assurance Program, a program that I've advocated for, a program that I know does such tremendous work. Well, it's also a program that's being zeroed out in this proposed budget. And so those that really care about health equity, I think, should definitely advocate to the council about providing the resources necessary so that our lower income, new American families, immigrant families, have the resources necessary to get the health care that they deserve. And so I don't know if there's time for questions. I know this is a webinar type of thing, but I'm definitely here for a few more minutes. I want to thank you guys again for having me, and know that every single day in Annapolis, I'm making sure that Prince Georgians are provided for. Thank you guys so much.
Thank you. And Leah, before you jump, because I know Delegate Martinez can't stay to the whole session, so I wanted to give this time in case someone do have questions for him. They can ask the questions now, and then all other questions will wait to the end.
Feel free to raise your hand and I can unmute you if you do have a question.
No questions. Okay. Well, thank you, Delegate Martinez. That was excellent. I'm sure, I'm going to move along in the presentation, but thanks. I'm sure we all will look at that RAND report and definitely go back and review the bills 865 and the other one. I can't remember that quick, but thank you.
1293.
Yeah. Okay. So proud of the work that you're doing and looking forward to, reading more. And I'm definitely on board with you as regarding to supporting the legislation and providing resources necessary for the immigrants and for all the residents of Prince George's County, the resources that they deserve.
Well, thank you guys again. And any way I can be of service, anyone on the call needs me, please don't hesitate to reach out. I'm here to serve. So thank you guys.
Thank you.
Bye.
Bye.
Next up, we have Leah Chambers, and she'll talk to us about how to make health equity practical. Leah?
All right. So, hello, everyone. Again, my name is Leah Chambers. You can go to the next slide, please. So before we get started, and just to piggyback off of what Twanisha mentioned earlier, it's essential to establish, really honestly, a clear understanding of what health equity means. And I'm just going to give it to you a little bit in short. Health equity is defined as everyone having a fair and just opportunity to attain their highest possible level of health. This concept is closely related to, but distinguished from health disparities, as we mentioned earlier. But let's explore that a little bit more in the next slide. So next slide, please. So health equity versus health disparities, there's a difference. Before we jump in a little bit more into my segment, it's important to note the biggest difference. And again, I want to make it a little bit shorter. Health disparities refer to measurable differences in health outcomes and opportunities between various population groups. These disparities often stem from social, economic, and environmental disadvantages faced by certain communities. Examples include higher rates of chronic diseases, lower life expectancies, and reduced access to quality health care among marginalized populations. Achieving health equities requires proactively identifying and eliminating these disparities. I'm going to say that one more time. Achieving health equity requires proactively identifying and eliminating these, meaning health disparities, while also addressing the underlying injustices and systematic barriers that contribute to them. This involves not only improving access to healthcare services, but also addressing social determinants of health, such as poverty, education, housing, and discrimination. In the context of primary care, promoting health equity means ensuring that all patients, regardless of their background or circumstances, have an equal opportunity to attain optimal health outcomes. This requires an effort to identify and address disparities within the patient population served and to implement targeted intervention to close these gaps. By understanding the distinction between health equity and health disparities, primary care providers can develop a more comprehensive approach to promoting equitable health outcomes to all of their patients. Next slide, please. So I'm going to put in a little bit more of what I mentioned before, because there was a slide that was mentioned. So making health equity practical in primary care and then putting health equity into practice. I'll summarize that a little bit more. So now that we have that clear distinction, it's just really important to understand and ask the questions as previously mentioned in the slide is, what does that day-to-day look like for primary care providers? How exactly can you implement those steps? And honestly, how you achieve health equity involves directly addressing those injustices and those key strategies that we had in the last section that we discussed is really going to be the drivers to advance health equity. So putting health equity into practice, that's really key, right? So we explored those steps in making health equity practical in primary care settings, but how you can put that into practice is taking those key strategies that was on the previous slides and putting that into action. Now, keep in mind, it's essential to recognize health depends on more than medical services to make it practical for primary care. Here are some ways to translate health equity from idea to impact. First, as previously shared in the previous slide, looking beyond clinical needs means addressing the social drivers of health. This involves forming partnerships with community organizations that tackle issues like housing instability, food insecurity, and transportation barriers. Next, rethinking systems and policies might include ensuring that all patients have access to telehealth services regardless of their technological capabilities or language preferences. Diversifying care teams to reflect the community served and actively including community voices in decision-making processes are also crucial steps. This can involve recruiting staff from diverse backgrounds and establishing patient advisory boards to guide practice policies. And finally, to go a little bit more in depth, collecting and analyzing data to reveal disparities is essential for targeting resources effectively. For example, comparing diabetes outcomes across different racial or income groups can help identify where additional support is needed. Next slide, please. And finally, advancing health equity. In addition to strategies mentioned earlier, achieving and advancing health equity in primary care involves empowering patients and communities to be agents of change. This includes providing education or self-advocacy and connecting them with local grassroots initiatives. Prioritizing equity initiatives in collaboration with stakeholders, such as joining community health equity task force, is really important as well. You just have to look at your local health centers and also to like resources like Prince George's Health Department, just to provide those resources as well. Finally, holding yourself accountable for equitable outcomes by tracking progress on disparities over time is essential for driving meaningful change. Promoting health equity in primary care is an ongoing journey that requires a commitment to addressing injustices, breaking down barriers, and eliminating disparities. By incorporating these practical strategies into daily practice, asking those questions on how can you implement health equity into your day-to-day work, and then also to looking at the organization entirely to see how you can implement that is how primary care providers can take significant strides towards ensuring all patients have an equal opportunity to attain optimal health. The road to health equity is a journey, not a destination. By weaving these approaches into primary care practices, we can take pivotal strides towards a future where everyone can attain their highest level of health and well-being. As primary care providers, you have the power and platform to catalyst this transformation. The path forward starts with making equity an explicit priority and committing to tangible action. Our patients and communities are counting on you to lead the change. So we went over a lot today on how to make health equity practical, but what I want the team and providers to understand, and the biggest takeaway from today's presentation is that they are the leaders to drive equitable change in primary care settings. But also remember, it takes a village for this change, and utilizing the resources accessible to support and offer equitable medical and social services to care to all patients is what will make health equity practical. And that concludes my portion of today's webinar.
Thank you very much, Leah. And next we will hear from the village. We're going to have stories from the community health workers, Denise Feliz and Magali Esquivel. Ladies?
Okay, so Denise was not able to make it. She's at a conference regarding community health workers workforce and building the community workforce and looking at sustainability efforts. So she's not here. So she do have a story from one of her patients, which I will share. Patient X faces monthly struggles with food insecurities. There was limited resources, often forced for her to choose between buying groceries and covering essential expenses like medication and utilities. By connecting patient X with local food pantries, she gains access to nutritious food options that alleviate some of her financial burden. With this support, my patient can better prioritize her health needs, ensuring she has enough food to sustain her and her family and maintain her overall well-being. Access to food pantries not only provide essential nourishment, but also offers a sense of community and support during challenging times. And so it's critical that, we always say it's important to get healthy foods. And we know sometimes the healthy foods can be expensive. And we have patients facing the decision, do I pay to keep my lights on and I just stop by and get something off the dollar menu from McDonald's? Or do I go to the grocery store and buy healthy foods? And so we try to partner with our local food banks and, community-based organizations that has the food pantries to connect the patients to those resources. So our community resources has they're putting together this whole resource guide to share with the practice and the patients to show what resources are available and to help the patients get connected, not to just give them the list, but if they can help, if they need transportation to get there, if they need to help get connection on a phone to make sure they have the right contact information, the CHW are there to help them navigate through those process and to make sure that they get connected to the resources so that they can also not have to worry about eating but healthy, but also can focus on their health. Okay, Magali.
Hello, everyone. So my name is Magali. I am a community health worker at the Family Medical Counseling Service. I work there as a community health worker, and so far it has been a wonderful adventure. I have been able to work one-on-one with providers and healthcare staff in order to deliver an equitable care for those in need. I have had the honor to contribute in helping and guiding many patients. For example, providing food resources to local food pantries, informing them on accessible transportation or insurance for healthcare services, and much more. Not only have I made a change in their lives, they have definitely made a impact on mine. So one of the stories I would like to share upon my experience would be the story of Mrs. R. I was directed to call this patient because she spoke Spanish. So I was able to break that language barrier and dig deeper on how I could further assist her. Initially, I was asked to ask her how she was doing because her A1C level was high. So I started by asking her how was she feeling? You know, I was trying to initiate a trusting relationship in order to have her open up to me to see how I could further help her. Um, but unfortunately, she was not interested in my help at first. So I definitely kept digging deeper, seeing how I could comfort her, how I could help her, how every patient has a different technique to speak to. But I definitely started with, just little by little. I led the conversation by finding out her story. I was able to support her and assist her by listening to her mainly. But she was not interested in the diabetes prevention program at the moment because she was working and she did not have time at the moment. But that didn't stop me from further pursuing how I could just be there for her as a community health worker. So by digging deeper, I did find out she needed a referral for her diagnosis of hyperthyroidism, and she needed to find a specialist. So I started there and I was able to help her with her needs. And then by her trusting in me, I was able to dig deeper on how I could help her more. And shortly, I found out that she needed help with food assistance and insurance. And we just created a beautiful bond. I check up on her regularly. She's one of my favorite patients. Not that I have preference, but I discovered that just by guiding her and showing interest in her, not only in her health, but in her life, it allowed me to just aid for her needs. Um, so that's probably one of my favorite stories to tell because it does show my work as a community health worker in the field. So I do prioritize maintaining regular communication with all my patients, particularly within a 3-month time frame, because that's usually when we do ask for an update in your A1C if you were to be closely monitored. But it does allow me to have a connection with you and just keep an eye on you and your progress. But this and much more represents on what I do as a community health worker in the field. Thank you for listening to me.
Thank you, Magali. And Magali, we have several CHWs that's working with prevention link providers, like with Dr. Lambert. We have Daniela, who assists with patients to get them enroll into DPP programs or DSMES, but also, again, to help them with any social determinants of health barriers. And we have Magali, who's at family medical counseling. And we have Denise, who's at Dr. Reed. I think Jennifer is on the call on a meeting as well. And she's also with Greater Bay. I'm not Greater Baden, I'm sorry, Gerald Family Care. And as we build a prevention link network, we also trying to build our community health workers workforce as well, so we can have them stationed within the different practices and federal qualified health centers. Thanks, Magali. Tanya, okay, so next slide, please. So we know that there's always challenges, and also when there's challenges, we look for opportunities. So also, I just want to mention like some of the challenges that hinder progress towards equity in Maryland is persistent socioeconomic disparities that continue to hinder the progress toward health equity, and marginalized communities face limited access to quality health care and resources. Additionally, cultural barriers along with institutional bias present significant challenges that must be addressed to ensure that all residents have equal opportunities to achieve optimal health outcomes. And we play a huge part in that as part of the care coordination team. Also, opportunities for improvement towards health equity in Maryland includes strengthening community partnerships, which we're doing. We collaborate with providers, with federal qualified health centers, with community-based organizations, also with payers such as the insurance companies, also with legislation the executive committees as well. We want to just make sure we're addressing the local health needs. We also invested in social determinants of health interventions, such as finding affordable, or try to reach out to find affordable housing and access to healthy food. We know sometimes that can be challenging throughout the state of Maryland, not just in Prince George's County. We also just want to make a significant impact. Additionally, promoting diversity and inclusion in healthcare delivery and the workforce can help reduce disparities and improve access to culturally competent care. Next slide. So future priorities that we're focusing on here in the county, and I'm sure across the state of Maryland as well, is implementing evidence-based interventions to address social determinants of health. So we have funding to, again, to surpass community health workers and the community to help patients with those social determinants of health needs as well. Also monitoring and evaluating health equity initiatives involves tracking metrics such as access to care, health outcomes, satisfaction levels among diverse population, allowing for the identification of successful strategies and areas needing enhancement to ensure that all individuals have the opportunity to attain their highest level of health. And again, I would really recommend that everyone on the call take a chance when you have a minute to look at the Prince George's County Community Health Assessment. And we have a link to that in the presentation, which will be shared with all of you guys. Also, advocating for policies. That's why we have delegate here as well. We want to continue to advocate for policies that promote health equity at the local, state, and national levels, involve engaging with policymakers, community leaders, and stakeholders to raise awareness about disparities, propose legislation changes, and support initiatives that address the root cause of inequities, ultimately striving to create a more just and inclusive healthcare system for all. And lastly, fostering collaboration across sectors to create sustainable solutions and achieving meaningful progress towards health equity goals involving engaging diverse stakeholders such as healthcare providers, community organizations, government agencies, and business to develop integrated approaches that address the complexity of social, economic, and environmental factors impacting health outcomes, ensuring that efforts are coordinated and resources are leveraged effectively. Okay, next slide. So again, we thank you for partnering. We hope that you had a chance to hear strategies that you can implement. Also, like to understand what the state of Maryland is doing, as well as Prince George's County Health Department to, tackle health equity and health disparities. And also, there will be more health equity webinars that we will have in the near future. We're having one in May and June. And before I move forward, I'll let Judy just provide some information regarding those upcoming webinars.
Thanks, Tornisha. So the next one will be sometime the third week of May, and we're going to be focusing with a panel of a nurse, a registered dietitian, and also a pharmacist to talk about health equity as it relates to diabetes for the specific populations. We have one of the, just as a pre, because she's definitely agreed to participate, is a assistant professor at the University of Maryland School of Nursing, and her area is around foot care, believe it or not, for the patients with diabetes. In fact, if you haven't had a chance, if you've not seen it yet, I'm happy to share with you. Prevention Link just released its April issue of the newsletter, and she actually has an article in there. So she's going to be fantastic. But we also, one of the great partnerships that Prevention Link has is with Giant Food. And oh my goodness, you guys, today I was watching some of their videos earlier that they have that you can watch on everything from diabetes to they even have a cook along, and they do it, it's international, and I used to teach an international vegetarian cooking class, so I'm excited to look at it. It's coming up in a couple weeks, but highly encourage you and recommend that you take a look and share these free resources with folks. The next webinar will be in June, and it's going to focus more around the social services aspect of health equity and diabetes, but you're welcome to join. I think that everybody would have an ability to have a tidbit of information that would be useful to them. So that's all I have to say on that, but we're so excited that you joined us today. Thank you, each and every one. I appreciate you being here, and we all feel your support. So thank you very much.
And so now we'll open it up for questions, comments, recommendations. Feedback. No questions? Okay, well, we will have a poll, and I think it's going to appear on the screen. And Amarachi, just let me know if that's correct. And as she's pulling up the poll, again, as Judy said, thank you so much for joining the webinar, and we look forward to you attending our future webinars. And in closing, I just want to make a statement. Achieving health equity requires a collective effort and commitment to address the underlying social economics factors that contribute to disparities in health outcomes. By working together, we can create a more just and inclusive healthcare system that ensures everyone has the opportunity to lead a healthy life. Thank you for joining us today, and we look forward to you continuing this important conversation and making progress towards health equity in Maryland and beyond.
Thank you. Once I end the presentation, a automatic survey will pop up. So please fill out all the questions, and we look forward to seeing you in the next one.
Thank you.
Bye, everybody.
Bye-bye.
Thank you.
Bye.